chose medicine because I find no other profession as challenging, as rewarding, as evolving, and as noble as this one. Yes, ask any parent, no matter what their profession is, they would be very happy if their child wants to become a doctor. Go to the school and ask the children there. And most of them want to become a doctor, and you are already it. Yes. So don't give up. You are the chosen one. You have done it. You can do it and you will do it. Just don't give up. You have great responsibility on your shoulder and you can do it. So now we start with a very important topic for your exams, and that is the arterial supply of the nose. The arterial supply of the nose, epistaxis, management of epistaxis is a question that is asked almost every year because that is an emergency condition. So yes, we need to understand properly what the arterial supply of the nose is, and once you have understood it, I'm sure you're never going to forget it. So the arterial supply of the nose is both by internal as well as by external carotid. Now from the internal carotid, we have the ophthalmic. Now when I say ophthalmic, what comes to your mind? Ophthalmic means, yes, it is supplying the eye. Yes, so now I'm giving you two options, okay? Ophthalmic enters the eye through two options, optic canal or supraorbital fissure. In between the eye and the brain, we have only these two connections. So from the brain, if the ophthalmic, which is a branch of internal carotid, yes, so from the internal carotid is the ophthalmic, which enters first the eye. Tell me quickly, which foramen? Yes, it is through the optic canal. So now it has come into the eye, and once into the eye, the ophthalmic artery gives the two branches, the posterior ethmoidal and anterior ethmoidal. So now it has entered into the eye through the optic canal. And now it will give two branches, the posterior ethmoidal and the anterior ethmoidal. And now these two branches from the eye have to enter into the nose. So when they have to come into the nose through the eye, obviously they are going to pierce the common wall. What's the common wall between the orbit and the nose? Yes, that is this wall. What is this? Yes, this is the lamina papyracea. Yes, so they will pierce the lamina papyracea through the same name foramen. The foramen that is present posteriorly, this foramen is the posterior ethmoidal foramen, and the one that is anterior is the anterior ethmoidal foramen. So both these will pierce through the lamina papyracea to enter into the nose. Now, while entering into the nose, the anterior ethmoidal, just see here, it produces a projection here, a bulge here. And this projection is a very, very important area that we need to see before we operate any patient for FES. Whenever we do a functional endoscopic sinus surgery, this is the area that we need to see before operating. Why? Yes, now just see. Now once the anterior ethmoidal is into the nose, so where it enters, there it produces the projection. Now this projection is what is known as the anterior ethmoidal notch, or it is also known as nipple sign, right? Now once it is into the nose, it gives some branches to the lateral wall, and then it runs through a very thin mesentery to reach the cribriform plate. From there it comes to the septum and it gives branches to the septum. Now why it is important to note where it is entering into the nose is that this can be either a safe entry. Safe entry means that it is entering above the anterior ethmoidal air cells. So the air cells, we know that here we have the ethmoidal air cells. So the air cells, maybe they have finished just below that entry, which means that this is a safe variety where we know that if we are operating on the anterior ethmoidal air cells, we are not likely to encounter it, so the chances of injury will be very minimal. Now, by chance, the anterior ethmoids here are very pneumatized. So, as we are seeing in this patient, the anterior ethmoids are extending up till here, and we can see that this artery is passing through the ethmoidal air cell to reach the cribriform plate. So if this is a patient where the anterior ethmoids get infected very badly, so in between the infection of the anterior ethmoidal air cells is this artery running. So while we are removing the disease from the anterior ethmoidal air cells, there are high chances of this artery getting injured. So before operating, you have to see where the artery is running, because you have to be very careful while you are removing the disease from that area. You cannot just blindly open the forceps and pull out everything there. Yes, if at all you're not careful, if you're not sure, you have not seen earlier where this artery is, and you injure this artery, then what will happen? What at all? Yes, it can lead to a orbital hematoma. This artery, it is coming from the orbit into the nose. So when it is injured into the nose, it will retract back into the orbit. And when it retracts back into the orbit, it will lead to a hematoma there, and this is an emergency condition. Why is this an emergency condition? Because we know that orbit all around is bony wall. Yes, which means that if hematoma occurs, there is no space for expansion. So if there is no space for expansion, what will happen? It will compress on the optic nerve, and that can lead to blindness. So if this at all occurs, if you have not been careful, so this orbital hematoma needs to be drained immediately. So, and what you need to do also is you need to immediately first ligate this artery. You need to ligate this anterior eighth module. So, how will you ligate the anterior eighth module? So, for that you know that how the anterior eighth module is coming from the orbit into the nose. So, we know that it is piercing the ethmoidal foramen. So, how we can ligate is either endoscopically through the nose, but that is very difficult when the patient's sinuses are infected. There is a lot of disease there. To identify this artery is not easy there. Easier method is the external approach. So what is the external approach is that you give an incision here. You give an incision here just below the medial part of the eyebrows, that is known as the medial canthal incision. And what you do is you raise the skin here, and you go up till the anterior eighth module foramen. So you need to exactly know how much distance you have raised that you will reach this anterior eighth module and the posterior eighth module foramen, because we know that just behind that we have first the anterior eighth module foramen, and then we have the posterior eighth module foramen, and behind that we have the optic nerve here. Right? So we do not want to damage the optic nerve. We do not want to be in a hurry and raise everything and damage the optic nerve. Yes, so we have to know exactly where this anterior eighth module foramen will be, where we are going to spot this artery, and that is where we are going to ligate it. Yes, this is around 24 millimeters behind the anterior lacrimal crest. Behind the anterior lacrimal crest, yes, and the posterior ethmoidal is around 12 millimeters behind the anterior ethmoidal foramen, and the optic canal is around 6 millimeters behind the posterior ethmoidal foramen. Now don't get confused. Okay, this is very simple to remember. It is very simple to remember. We have the anterior lacrimal crest. Lacrimal crest is, we have the lacrimal sac here, right? The lacrimal fossa. So in the lacrimal fossa is the projection that is known as the anterior lacrimal crest. So we have the anterior lacrimal crest. Behind that 24 millimeters. Okay, so it is 24, then it is 12, and then it is 6. Is that clear? So we have anterior ethmoidal foramen, then posterior ethmoidal foramen, and then we have the optic canal. Okay, so that is easy to remember. And this incision that we give is what is known as the Lynch-Haworth incision. So in your exam, this incision is shown like this. The incision is shown like this, and it is asked, what is this incision? Yes, so this incision is named as Lynch-Haworth incision or Lynch-Haworth approach. So now once into the eye, it will give the lateral branches. The ethmoidal will then go to the cribriform, through the cribriform plate to reach the septum, and then it will give branches to the septum. So the anterior ethmoidal supplies the anterior part of the septum, whereas the posterior ethmoidal supplies a very small part posterior-superiorly. Okay, so now what are the branches of the internal carotid? Let us quickly write down. Yes, and you are going to tell me as I go on writing this. Yes, so from the internal carotid we have the ophthalmic. The ophthalmic gives what branches to the nose? Yes, ophthalmic gives the 2 branches. What are the 2 branches? Yes, we have the anterior ethmoidal, and we have posterior ethmoidal. Anterior ethmoidal enters the nose through, yes, the anterior ethmoidal foramen, and this enters through the posterior ethmoidal foramen. Yes, in your exam last year was given this picture, the CT scan, and was asked the marked structure is. Yes, the marked structure is, and in the choice was anterior ethmoidal artery. So yes, the marked structure is the anterior ethmoidal artery, and has been asked earlier also, what is the sign known as? This sign is known as nipple sign. So from the anterior ethmoidal foramen where it enters, that is what is known as the anterior ethmoidal notch, or the nipple sign, on CT, on CT, and then it comes to supply the nose. So in the nose, it supplies lateral wall as well as the septum. So here this also enters and it supplies the nose. Same, it supplies the lateral wall as well as the septum, a very small part of the septum posterior superiorly. Is that very clear? So now, is that absolutely clear? You are never going to forget it ever. Yes, is that clear? That has to be that clear. Okay, so quickly tell me, what is the arterial supply from the internal carotid? Yes, quickly, from the internal carotid, ophthalmic. Ophthalmic comes here into the orbit, posterior eighth model, anterior eighth model, through the lamina papyracea, enters the nose, lateral wall and the septum. And where it enters, anterior eighth model notch or anterior eighth model foramen. And if we have to ligate this, where are we going to ligate it? Yes, how much behind the anterior lacrimal crest? Yes, anterior eighth model is 24 and posterior eighth model is 12 millimeters behind the anterior eighth model. And what is this incision known as? That is Lynch-Horvath incision, Lynch-Horvath approach. Yes, so it is something like this, and you must have seen this diagram earlier, but now you will exactly understand what is this diagram showing. So here we have the ophthalmic entering into the orbit, and it is giving this branch here. This is the posterior eighth model. It is giving this branch here. This is the anterior eighth model entering the nose, and it is going up till the cribriform plate. We can see here up till the cribriform plate, then to supply the septum. So that is all you need to know about the arterial supply by the internal carotid system. Is that clear? Okay. So now let us quickly see what are the important questions that are asked here. Yes, injury to which artery during FEST results in orbital hematoma? Which artery? Yes, anterior ethmoidal. Anterior ethmoidal. What is the incision to ligate anterior ethmoidal? Yes, this we have written. It is Lynch-Horvath. Anterior ethmoidal notch is also known as, nipple sign. Nipple sign. So now coming to the branches of external carotid that supply the nose. So external carotid, can you tell me where is the external carotid? Yes, external carotid, where is it here in relation to the nose? Yes, external carotid is going, yes, at the bifurcation we have the internal carotid and then we have the external carotid. External carotid travels up and it gives multiple branches. Yes, that is how we differentiate between the internal and the external carotid in the neck. Internal carotid has no branches in the neck, whereas external carotid has multiple branches. Quickly tell me the branches of the external carotid. Yes, tell me the branches of external carotid. Tell me the first branch. First is the medial branch, ascending pharyngeal. Second is, yes, superior thyroid, that is the first lateral branch. And then we have, yes, we have lingual, we have facial. The posterior branches I'm not telling you. Yes, the occipital, posterior auricular. We can just leave it because we are doing about the nose here. Yes, nose is here anteriorly. So we have the lingual, we have the facial, and we have the terminal branch, that is the maxillary. So out of these, which one supplies the nose? Yes, the main artery supplying the nose is the maxillary, along with some contribution from the facial. So we have the maxillary and the facial. These are the two branches of external carotid that supply the nose. Now, before we write that down, yes, you are going to quickly tell me that the maxillary, how is it entering into the nose to supply the nose? Yes, the maxillary, where is it? Yes, maxillary is in this area. It is given off in this area. What is this area? Yes, this is the infratemporal fossa. So from the infratemporal fossa, how is it reaching into the nasal cavity? Yes, this is something which you need to understand. This is important for you. Yes, so how is it entering into the nasal cavity? Yes, so from the infratemporal fossa, it first enters the sphenopalatine fossa. Now, we have done sphenopalatine fossa in great detail when we did the nerve supply of the nose. I hope you remember that, but I am quickly going to review it just in case you have forgotten it. So, here we have the sphenopalatine fossa. For the boundaries, so we have the antrum. This is the maxillary antrum. Maxillary antrum is the maxillary sinus. This is the anterior wall of the maxillary sinus. This is the cavity, and this is the posterior wall of the maxillary sinus, right? Now, behind the posterior wall of maxillary sinus, from the sphenoid bone comes down two bones. These are the two pterygoid plates. These are the pterygoid plates. This one. This is the pterygoid plate. Now, this area that we are seeing, let me rub it so that it becomes clearer. So, this area that we are seeing in between, anteriorly, the posterior border of maxillary sinus, and posteriorly, the anterior border of the pterygoid plate. This is the sphenopalatine fossa. So, let us quickly see how it looks three-dimensional. Now, the medial wall of the maxilla is the same as the lateral wall of the nose. Yes, we know that. If we have a look through the maxilla, that's the medial wall of maxilla that we are seeing. If we see through the nostril, that's the lateral wall of the nose that we are seeing. So suppose this here is the lateral wall of my right nostril. This is the lateral wall exactly like this. Now here this is the maxillary sinus, this is the skin of the cheek. Now I have removed the skin of the cheek, so what I can see behind that is the maxillary sinus, right? It is like this. So here we have the orbit here superiorly. This is the anterior wall of the maxillary sinus, the cavity inside, and this is the posterior wall of the maxillary sinus. Now behind the maxillary sinus, we have the pterygoid plate. So if I show you like this, it is something like this. So from the base of skull is coming down two plates. So these are known as the two pterygoid plates. What you are seeing from there, that one is the lateral pterygoid plate, and the medial pterygoid plate is towards me, right? Now this space that you are seeing, are you seeing this space in between anteriorly? Yes, where my little finger is here. In between anteriorly, the posterior border of the maxillary antrum, and posteriorly the anterior border of pterygoid plate. Yes, that is the sphenopalatine fossa. Now if I ask you to quickly tell me the boundaries of the sphenopalatine fossa, yes, quickly tell me the anterior boundary. Anterior boundary is the posterior border of maxillary antrum. Posterior boundary is the anterior border of the pterygoid plate. What is the lateral boundary? Laterally, can you see it is open? Yes, it is open in between the maxillary antrum and the pterygoid plate. This is what is known as the pterygomaxillary fissure, through which it communicates with this area. What is this area? Yes, this is the area lateral to the maxillary antrum. This is the infratemporal fossa. So quickly tell me the boundaries of the sphenopalatine fossa. Yes, anteriorly we have the posterior border of maxillary antrum. Posteriorly we have the anterior border of pterygoid plate. Laterally, yes, what is this laterally? Can you see? Yes, laterally it is open. Yes, laterally it is open. This fissure in between the pterygoid and the maxilla is what is known as pterygomaxillary fissure, through which it communicates with this area. What is this area? Yes, this area is the area. This is lateral to the maxillary sinus. So lateral to the maxillary sinus, this is what is known as the infratemporal fossa. And what's the medial boundary? What's the medial boundary of the sphenopalatine fossa? Yes, what is this? This is the medial boundary. What is this? Yes, this is the lateral wall of the nose. Yes, now I have told you earlier also that the lateral wall of nose ends at the posterior border of the turbinates. Yes, so this area exactly lies little behind the turbinates, and here on this wall, on the medial wall of the sphenopalatine fossa, is a foramen. This is what is known as the sphenopalatine foramen. The vessels and nerves which supply the nose are present in the fossa, and through the foramen they come to supply the nose. So now where is the maxillary artery? It is present here in the infratemporal fossa. From here it goes into the sphenopalatine fossa, and here it gives a very important branch to the nose. The name of the artery is the same as the sphenopalatine foramen, that is sphenopalatine artery. It is known as sphenopalatine artery because now it is going to enter into the nose through the sphenopalatine foramen, and now it will come to supply the nose. So it will come from here to supply the nose. Is that very clear? Okay, so here we have the anterior wall of the maxillary antrum, the posterior wall of the maxillary antrum, and this is the pterygoid plate. So this space here, this is the sphenopalatine or the pterygopalatine fossa, and this lateral to it is what is the infratemporal fossa, where the maxillary artery is present. Now the maxillary artery will go into the sphenopalatine or the pterygopalatine fossa. Right, so it has entered into the sphenopalatine fossa, and here it will give two major branches to the nose. Yes, one is the greater palatine. Just note here, the greater palatine will from here enter through the greater palatine foramen, that is just below, just medial to the third molar. It will enter into the palate. It will supply the palate, and then it will come up to supply the nose. Is that clear? The other branch is the sphenopalatine artery that I just showed you in the model. The sphenopalatine enters the nose through the sphenopalatine foramen that is present 1 centimeter behind the posterior end of the middle turbinate. A very, very important question this is. Yes, 1 centimeter behind the posterior end of middle turbinate. 1 centimeter behind the posterior end of middle turbinate. Yes, we have done this earlier, but I am repeating it because this is very commonly asked. Yes, this is the sphenopalatine foramen. So from here enters the sphenopalatine artery. The sphenopalatine artery will come and it will supply the lateral wall. and then it will go posteriorly to come up till the septum, and then it will supply the septum. So from the external carotid, we have this artery. This is the sphenopalatine. We can see it is coming from posteriorly to supply the septum. We have the greater palatine, which first supplies the palate and then comes up to supply the nose. And we have another branch of external carotid supplying the nose, and that is the septal branch of superior labial. The superior labial septal branch. Septal branch of superior labial. So before we proceed, we are quickly going to write the arterial supply of the external carotid supplying the nose. So from the external carotid, quickly tell me which branches? Yes, so from the external carotid, we have the two branches. We have the maxillary and we have the facial. Right? So from the maxillary, we have again two branches. We have the greater palatine, and we have the sphenopalatine artery. Yes, and from the facial we have the septal branch of superior labial. Now these arteries, which are branches of the internal external carotid system, now they anastomose on the septum. Yes, remember that it is not the lateral wall, it is the septum. In the anteroinferior part of the septum into this area. Can you see this area? Yes, this is the area on the septum, on the anteroinferior part of the septum. Anteroinferior part of septum, where all these arteries from the internal system as well as the external system anastomose. And this is a very, very extremely important area of the nose, of the septum, and this is what is known as the Little's area. And the plexus that is formed by these arteries here is what is known as the Kisselbach's plexus. Kisselbach's plexus. Now please note here, in the Kisselbach's plexus, we have the anterior ethmoid, we have the sphenopalatine, we have the anterior ethmoidal, we have the sphenopalatine, we have the greater palatine, and we have the septal branch of superior labial. So which one have I missed out? Yes, the posterior ethmoidal, can you see that it is not a branch of Kisselbach's plexus? It does not supply the Little's area. That's a very important question of your exam, that not a branch. The posterior ethmoidal is not a part of Kisselbach's plexus. Not a part of Kisselbach's plexus. And which is the main artery supplying the Kisselbach's plexus? The main artery is the sphenopalatine artery. So we will first write that down. Yes, so the sphenopalatine artery is the main artery of Kisselbach's plexus, and not a part of Kisselbach's plexus is the posterior ethmoidal. Now this Little's area or the Kisselbach's plexus is present on the septum, and it is quite down, very accessible to nose picking. So this is the most common site of anterior epistaxis. So now before we proceed, you are quickly going to tell me, nose is supplied by only internal carotid, only external carotid, mainly internal carotid, mainly external carotid. Yes, quickly tell me first. Only internal carotid, only external, mainly internal, mainly external. Yes, it is mainly by external carotid. Which branches of external carotid supply the nose? Okay, I will give you the choices. Which branches supply the nose? Maxillary, yes or no? Okay, yes. Sphenopalatine? Yes. Greater palatine? Yes. Lingual? No? Septal branch of superior labial. That's the branch of lingual or facial? That's the branch of facial. So which branches of external carotid supply the nose? Maxillary and facial. How many branches from maxillary? Two branches. Which two branches from maxillary? Sphenopalatine and greater palatine. How many from facial? One. Which branch of facial? Yes, septal branch of superior labial. Other than external carotid, which artery supplies the nose? Yes, which branch of internal carotid? Ophthalmic. Which branches of ophthalmic? Anterior ethmoidal and posterior ethmoidal. Out of these, which is not a part of Kisselbach's plexus? Posterior ethmoidal. Where is the Kisselbach's plexus? On the septum or on the lateral wall? On the septum. Where exactly on the septum? Superiorly or inferiorly? Yes, in the anteroinferior part of the septum. So most common site of epistaxis in young, most common site of anterior epistaxis is Kisselbach's plexus. What is the area in which Kisselbach's plexus is present known as? Little's area. So the most common site of epistaxis in young is Little's area. The plexus in the Little's area is Kisselbach's plexus. What's the main artery supplying the Kisselbach's plexus? Sphenopalatine is a branch of maxillary. Yes, so which do you think will be known as the artery of epistaxis? Artery of epistaxis is another name for sphenopalatine artery. So sphenopalatine artery is also known as artery of epistaxis. Artery of epistaxis. So now you are going to quickly label these for me. You are going to identify this for me. Yes, identify one. What is one? Which artery? Very good, NT8 model. Two is? Yes, post-8 model. What is 3? 3. Yes, sphenopalatine. Yes, identify the artery of epistaxis. Which one here is the artery of epistaxis? Yes, the 3. Okay, and what is 4? Greater palatine. And what is this one? Yes, this is 5. What is this? This is septal branches of PL-ABL. Yes, this question has been asked earlier. In your exam, the arterial supply was given and the sphenopalatine was marked and was asked what this is. Has been the picture given in 1, 2, 3, 4 has been labeled and has been asked identify the artery of epistaxis. So which is the artery of epistaxis? Yes, artery of epistaxis is the sphenopalatine artery. That is the most common cause of epistaxis, whether it is anterior epistaxis, whether it is posterior epistaxis, the most common cause of epistaxis is the sphenopalatine artery. That is the main artery of the nose. Just identify this area. Yes, identify this area. What is this? Yes, this is the Little's area. Can you see how inferiorly it is present on the septum? Very accessible for nose picking. Yes, can you identify this? Yes, what is this? Here we have the lateral wall, that is the inferior turbinate. This is the floor of the nose, and yes, this is the septum. And can you see these arteries, all of these? Yes, this is how the Kisselbach's plexus looks like. And can you tell me what is the main artery of this area? Yes, the sphenopalatine artery. Yes, now identify this area. What is this area? Yes, exactly. We are having a look at the lateral wall of nose. So what is this area here? Yes, this is behind the middle turbinate. Yes, this is the area of the sphenopalatine foramen. Sphenopalatine foramen. Yes, which artery enters here? The sphenopalatine artery. So, which artery will be ligated here? Yes, the sphenopalatine artery. So, whenever we have to ligate the sphenopalatine artery, is it the most common cause of anterior as well as posterior epistaxis? Yes. So, if we have to ligate it, where will you ligate it? You know where it is entering into the nose. Yes, so whenever we remember the anatomy, we always have to know the clinical significance of whatever we are reading in the anatomy. So yes, this sphenopalatine foramen is the area where the artery is ligated. Is that clear? Okay, so quickly now tell me, the arterial supply of this nose is mainly by internal carotid or external carotid? Yes, it is mainly by external carotid. Location of Little's area, anterior-inferior part of lateral wall, septum. Anterior-inferior part of septum. Arteries contributing to Kisselbach's plexus. Okay, not contributing to Kisselbach's plexus, that is posterior model. And then many a times you just remember posterior model does not contribute, and what contributes? You forget that. Yes, what contributes? What contributes? Yes, from the internal carotid we have anterior model. Yes, from the external carotid. This is from the internal carotid. So, from the external carotid, we have the maxillary and the facial. From the maxillary, we have the sphenopalatine and the greater palatine. Yes, so all these contribute to the Kisselbach's plexus. Which does not contribute is the posterior ethmoidal. What is the most common cause of anterior as well as posterior epistaxis? Yes, it is sphenopalatine artery. Yes, what is posterior epistaxis? Posterior epistaxis is considered to be posterior to the maxillary sinus ostium. So, where the maxillary sinus ostium opens into the middle meatus, anterior to that is called as anterior epistaxis, posterior to that is called as posterior epistaxis. Yes, anterior epistaxis can be very easily visualized. Posterior epistaxis is something that you cannot visualize from where it is coming. So, that is why it has been labeled as two anterior as well as posterior. Or it is also said that another mode of classification of anterior and posterior is that anterior to the piriform aperture is anterior, posterior to the piriform aperture is posterior. What is piriform aperture? Yes? Yes, so this is the opening in the bone, the bony skull of the nose. That is the piriform aperture. This is the piriform aperture. So anterior to that is what is anterior epistaxis, posterior to that is posterior epistaxis, and be it anterior or posterior epistaxis, the most common arterium, most common cause is the sphenopalatine artery. So it is also known as artery of epistaxis, the sphenopalatine artery. And where is it ligated? Yes, it is ligated in the nose. It is ligated in the nose at the sphenopalatine foramen. Where is the sphenopalatine foramen? 1 centimeter behind which turbinate? Middle turbinate. So all are the questions that have been asked earlier in your exam. Now epistaxis is mainly arterial or is it venous? It is mainly arterial or is it mainly venous? We just read, no, that this is Kisselbach's plexus, it's the arterial plexus, these arteries form, so it is mainly arterial. But can epistaxis, that is bleeding from the nose, be also venous? Yes, it can be. It can be venous both from the septum as well as from the lateral wall. Now, if it is from the septum, then the site is behind the columella of the septum. So, what is the columella of the septum? Yes, the lowermost part of the septum, where the medial crura of the lower lateral cartilage, the alar cartilage, medial crura is meeting, that's the columnar septum. Just above that, just behind that, runs the vein which is known as retrocolumnar vein. So this is a part of it is in the part of the septum where from here venous bleed can occur, and also from the lateral wall is the area from where venous bleed can occur. That is what is known as Woodruff's plexus, again a plexus that is asked in your exams, and this is a venous plexus. What is asked is this is a venous or arterial plexus. This is a venous plexus, and this is present at the posterior end of inferior turbinate. Again, this has been a question that has been asked in your exam. Posterior end of inferior turbinate. And this was considered earlier as the most common site of epistaxis, which is posterior epistaxis, but it is now no more considered as the most common site of posterior epistaxis. Now the most common site or cause of anterior as well as posterior epistaxis is, you tell me. Yes, sphenopalatine artery. It is arterial, not venous. So now we know all the sites of epistaxis. We know from where all epistaxis can occur, whether it can be arterial, whether it can be venous, which all arteries contribute. We know all of that now. Now, here we are sitting in the OPD or in the emergency, and here is a patient who has come to you with epistaxis. What is epistaxis? Yes, bleeding from the nose is epistaxis. Yes, so first we need to know what can be the causes of epistaxis. Yes, so epistaxis, always note, it is either seen usually in children or it is seen in elderly. So it has a bimodal age presentation. So we should know that if any child is presenting with epistaxis, what can be the most common cause? And if any elderly is presenting with epistaxis, then what can be the most common cause? So the most common cause in children is trauma. Trauma by nose picking. Then how will a foreign body present? A foreign body of the nose, will it not present with epistaxis? Is that not the most common cause of epistaxis in children? How many children do you see who keep putting foreign body? And foreign body does not present most commonly as epistaxis. It can present with blood-tinged nasal discharge. It can present with epistaxis, but that is not the most common presentation. In fact, the presentation of foreign body of the nose in a child is asked again in your exam. Yes, why? Because on suspicion you think that yes, this can be a foreign body. Parents, most of the time what children do, they will just keep doing something. They will not tell the parents also. So parents also do not know that the child has put something in the nose. And later on they come with a complaint that child is having pull and discharge only from one nostril. So any child who has come to you with a complaint that there is purulent discharge coming from only one nostril, and that can be a foul smelling nasal discharge, then always suspect a foreign body, and it is invariably a foreign body. So foreign body presents with unilateral foul smelling nasal discharge. Yes, there can be epistaxis, there can be blood-tinged nasal discharge, but that is not the most common presentation. And any child who is presenting with epistaxis, the first thing that you have to think of is that maybe the child has done nose picking, and that occurs very commonly following upper respiratory tract infections. Upper respiratory tract infections, they lead to a lot of dryness in the nose. So many a times nose picking is not in the choice. When the question is asked most common cause of epistaxis, what is given is upper respiratory tract infections. So that can also be marked if nose picking is not there, because the cause of trauma is dryness, crusting in that area, and the cause of crusting is upper respiratory infections. So it can be also upper respiratory tract infections like common cold. Yes. Whereas in adult, what do you think in elderly? Is hypertension the most common cause of epistaxis in elderly? That was considered as the most common cause of epistaxis in elderly. It is no more considered as the most common cause. It can be a cause because hypertension, prolonged hypertension, leads to vascular fragility. It can be a cause, but that is not the most common cause. Is that clear? The most common cause of epistaxis in adults or in elderly is idiopathic. Again, this is a question. It is idiopathic. Is idiopathic. Now, there can be many other local causes of epistaxis, the most common being these, and these are very repeatedly asked. What can be the other local causes of epistaxis? Yes, the other local causes can be other trauma other than nose picking. So, what can be other trauma? It can be a surgical trauma. Yes, it can be a surgical trauma, iatrogenic trauma like a septal surgery, septoplasty. Septoplasty. Epistaxis can follow FES, functional endoscopic sinus surgery. It can occur in deformities of the septum. It can occur in deformities of septum like in DNS. It can happen in DNS. Yes, it can happen in infections of the nose. Infections. Which infections? All granulomatous infections you will see can produce with blood tinged nasal discharge. So there can be granulomatous infection. Granulomatous infection. There is an infection of the nose, that is rhinosporidiosis, where patient presents repeatedly with epistaxis. Rhinosporidiosis. Rhinosporidiosis. Yes, any blood tinged nasal discharge in elderly can be a tumor. So there can be tumor. So only in elderly can tumors lead to blood tinged nasal discharge or epistaxis. Yes, tumors. It can be also in young. And here, very, very important, we have to remember, any recurrent epistaxis in a young male should be investigated for some tumor. Which tumor is that? Angiofibroma. And yes, we will do that in detail later on. But for now, when we are doing epistaxis, that has to be in your mind. Any child presenting with epistaxis, even if it is recurrent, the first thing that you will think of is a nose picking. Elderly, you will think of is, with epistaxis, you will think of is idiopathic. If it is any young male with recurrent epistaxis, then what should come to your mind immediately? Angiofibroma. So any recurrent epistaxis in young male, that is seen only in males and it starts during puberty. So in young males, not everybody. Yes, in young males, you have to rule out the tumor. Which one? It's a benign tumor, angiofibroma. Angiofibroma. Also drugs which are used locally inside the nose, they can cause a lot of dryness and they can lead to crusting and epistaxis. For example, what are the drugs that we use in the nose? Yes, nasal decongestants or the nasal steroid spray is very commonly used. So that is why whenever we put nasal steroid spray, whenever we ask the patient to put nasal steroid spray, you have to specifically instruct the patient. Nasal steroid sprays are used so commonly. Allergic rhinitis, vasomotor rhinitis, chronic sinusitis, everywhere it is used. So you have to instruct the patient that the nozzle of the steroid spray has to be laterally, not on the septum. Yes, that can lead to dryness on the septum. It can lead to epistaxis. So drugs like nasal decongestants or steroid nasal spray. All these can lead to epistaxis. Now, please keep it in mind that epistaxis is a repeated question of your exam. Epistaxis is a topic which is emergency. Yes, the patient lands up in emergency with bleeding and this is very commonly asked. So we cannot leave anything of epistaxis. We have to know everything of epistaxis. We have to know the arterial supply very beautifully. We have to know what can be the local causes in the nose which can lead to epistaxis. We also have to know what can be the systemic causes of epistaxis. Yes, so what can be the systemic causes of epistaxis? My God, do we have to remember this? Yes, we do have to remember, and believe me, it is very, very simple to remember this. So just follow me how we have to remember, and you will be able to remember each and one of these by the time we are quickly, maybe in 5 minutes. Yes. Okay, so for this, first we need to understand that whenever there is any trauma to any surface, suppose here we are talking about the nose. Okay, so wherever there is any trauma, immediately what happens is when there is damage to endothelium of the blood vessel, immediately to stop the bleeding, what happens is that platelets come to that area, and the platelets, they form a loose plug here to immediately stop the bleeding. Now later on, what happens, now this part till the platelet come, that is what is known as primary hemostasis. Now later on, what happens is to make this plug a very tight plug, the fibrin gets deposited in this area, and that occurs with the help of what is known as secondary hemostasis. So the primary hemostasis, this is primary, and here the fibrin, when the fibrin deposits, that is secondary hemostasis. So whenever there is any defect in either the primary hemostasis or the secondary hemostasis, there can be bleeding. Now in primary hemostasis, what can be the defect? So just listen to this very carefully. Now, whenever there is any injury on the endothelium, the primary hemostasis occurs because of the platelet forming the loose plug there, which means that if there is a defect in the primary hemostasis, it is because the platelets are not able to form that plug. So, if the platelets are not able to form that plug, why? Yes, because platelets are not adequate. Platelets are less in number. Why are they less in number? Either the production is less or the destruction is more. Yes, so this can occur either because of decreased production, or it can occur because of increased destruction, or also sometimes what happens is that the platelets are adequate but they are not functioning properly. So they are dysfunctional. Is that clear? So whenever the platelets are less in number, either because of decreased production or because of increased destruction, less platelets is what we call as thrombocytopenia. The platelets are known as thrombocytes. So thrombocytopenia, right? So what can be the causes of thrombocytopenia? Either decreased production. Decreased production can occur because of, where is the platelet produced from? Platelets are produced from where? Bone marrow. Yes. So whenever the bone marrow is not functioning properly, like in leukemias, or in myelodysplastic syndrome, where all the bone marrow products are very immature, small immature cells, myelodysplastic syndrome. Yes. So whenever any patient comes with epistaxis, it can be because of leukemia, because of myelodysplastic syndrome. You need not only know that these can be the causes, you also need to know when you need to suspect them. Yes, leukemia and myelodysplastic syndrome, all the blood cells, even the WBCs, the RBCs, everything is less. So patient will have anemia, because of which the patient will have lethargy. Patient will have WBCs less, because of which the patient will have recurrent infections. So patient will have anemia. Patient will have recurrent infections. And can you spot this leukemia myelodysplastic syndrome by a simple blood count, complete blood count? Yes. So whenever you are suspecting, you need to get the blood count done in a patient of epistaxis. Now it can occur because of increased destruction as in some conditions like, yes, there is an autoimmune condition which leads to increased destruction of the platelets, only isolated destruction of the platelets. That is what is known as ITP, or immune thrombocytopenic purpura. Earlier it used to be known as idiopathic thrombocytopenic purpura. Now it is known as immune thrombocytopenic purpura. So here also the patient will have decreased platelets, but only platelets will be decreased. Rest of the blood cells will be normal. Now also increased destruction can occur whenever patient has splenomegaly. So in the spleen, the sequestration of the platelets occur, the destruction of the platelets occur. So these conditions can lead to increased destruction of the platelets, ultimately letting less platelets to be there for the hemostasis to occur. Now also there can be a condition where the platelets might be adequate but the function is not proper. The addition function is not proper. Why? Because the component which is required for the addition of the platelets is not there. It is not functioning properly. So which is that component which is required for proper addition of the platelets? Yes, that is the von Willebrand factor. Von Willebrand factor. So in von Willebrand disease also the platelets are there but they might be adequate but they are not functioning properly. So that can also lead to a defect in primary hemostasis. Now there are certain drugs which can be antiplatelet like NSAIDs, like aspirin. Yes, so they can also lead to reduced platelet, and an infection is very commonly seen in our country. Dengue hemorrhagic fever. This also causes reduction in the platelet. So these are the causes where the platelet will go down. Yes, so quickly just think of it. Yes, when will the platelet go down? Yes, platelets are less either because of decreased production or increased destruction. Yes, decreased production occurs from where? From the bone marrow. So when the complete bone marrow is affected, as in leukemias, myelodysplastic syndromes can also follow radiotherapy, chemotherapy. Yes, also when the destruction is more, like in ITP or in splenomegaly, or the patient is taking certain drugs. Patients of heart disease who have artificial valve, they are given aspirin for a prolonged period. So in them also, the chances of bleeding is high. So there will be many elderly who will come with this complaint of epistaxis. So there you have to ask them that, are you taking aspirin? Yes, they will tell you. Most of them will tell you that, yes, I am taking aspirin. So that can be a cause because of which they are having epistaxis. So these are the causes where primary hemostasis is affected. Now, in all the patients who are having defect in the primary hemostasis, they can have epistaxis also, but that is not the only presentation. They can have other sites bleeding at the mucocutaneous areas, like they can have gum bleeding, they can have rashes, they can have patches, they can have bleeding on the skin. What is that known as? Yes, they are known as petechiae or purpura or ecchymosis. So it's a very superficial bleed. Now, all the patients who have defect in primary hemostasis, they can have epistaxis. Along with that, they can have bleeding from other mucocutaneous areas. They can have gum bleed. They can have menorrhagia. They can have genitourinary bleeding. They can have hematuria. Also, they can have on the skin, yes, small bleeding patches. They are known as petechiae when they are 1 to 2 millimeters in size. 1 to 2 millimeters, that is petechiae. Or if they are little larger, more than or equal to 3 millimeters, they can be purpura. They are known as purpura. Even larger is what is known as ecchymosis. Yes, so whenever there is defect in the primary hemostasis, always remember the bleeding is mucocutaneous. Bleeding is superficial. Is that very clear? So now we know what can be the systemic causes which can affect the platelet function and they can lead to bleeding. Is that very clear? Now let us come to the secondary hemostasis. Now secondary hemostasis occurs because of deposition of the fibrin, and this fibrin is formed because of through the coagulation cascade where clotting factors are required. So whenever there is a deficiency of the clotting factors, again there can be bleeding. So clotting factors are produced from where? Deficiency of clotting factors, so the production is less. Yes, so from where are they produced? Very good, they are produced from liver. Yes, so in decreased production as in liver diseases. Vitamin K is required for the production. So vitamin K deficiency, for example, in people who are in chronic alcoholics. Yes, if they come with, if any elderly or if any adult comes with bleeding, then you need to rule out this also, whether the clotting factor is normal or not. And in children, you have to rule out the genetic condition, hemophilia A and B, both. Deficiency of factor 8 and factor 9, hemophilia A and B. And there are many drugs, anticoagulant drugs. Which are these? Yes, you will have many people with heart disease, artificial valves, yes, taking these diseases, anticoagulant drugs like heparin, warfarin, Yes, so drugs can be local causes of epistaxis. Drugs can lead to interference of primary hemostasis. They can lead to interference of secondary hemostasis. So now, how will we differentiate whenever there is bleeding that we are seeing? There is epistaxis also. There is bleeding also. How is there some way that we can find out that this is because of defect of primary or because of secondary hemostasis? Or all the patients we need to get investigated for everything? Yes, coagulation profile also, and we need to investigate for the platelets also, for leukemia also, everything we need to investigate. No, primary hemostasis, the bleeding is always superficial. As I've told you, there will be petechiae, there will be purpura. Whereas in secondary hemostasis defect, the bleeding is deep in the muscles or joints. Yes. So if there is any child, okay, now just think, patient is presented to you with epistaxis, and this patient has, when you examine the body of the patient, what you see is small petechiae, purpura. What can be your DD? What can be your DD? Yes, if there is only epistaxis, nothing else, then yes, we know it can be because of nose picking. But if on the body you have to inspect, only when you know you will do that. Yes, when you inspect the body and you see small petechial rashes or purpura, so then what will you think of? Yes, then you will think of a platelet abnormality. Maybe it can be a von Willebrand factor abnormality. Yes, whereas what you're seeing is a picture like this in that child, then you will think of ruling out a hemophilia. Is that clear? Yes. So that is how we remember the systemic causes. Just remember defect in primary as well as secondary hemostasis. So now let us have a look at this table now quickly in 2 seconds. Yes. So systemic causes can be either because of platelet disorders. Now platelet disorders, when I am telling you this, you should be able to tell me before I name that. Yes, it is. Platelet disorders are known as decreased platelet thrombocytopenia. It can be either because of decreased production as in, yes, very good. Now you have to tell this, yes, leukemia or in myelodysplastic syndrome. Or it can be because of increased destruction as in idiopathic thrombocytopenic purpura or immune thrombocytopenic purpura, splenomegaly, or in impaired function like in von Willebrand disease, or in drugs. Yes, drugs, antiplatelet drugs. Half of the table is over. Yes. For the next half, defect in secondary hemostasis. Secondary hemostasis is clotting factor abnormality that can occur because of decreased production of the clotting factors. That can occur in liver diseases, in vitamin K deficiency. It can occur in hemophilia or when the patient is taking anticoagulants like heparin and warfarin. That's it. Yes. So now, do you have to rectify this table? No, it is absolutely clear. That is what you need to remember. So, do we know all the arterial supply of the nose? Keep your pens down. Yes, keep your pens down. Yes. Do you know the arterial supply of the nose? Arterial supply of the nose is mainly internal carotid, mainly external carotid. Mainly external carotid. Which branch of external carotid supply the nose? Maxillary and facial. How many branches from maxillary? 2. Sphenopalatine and greater palatine. Which is the artery of epistaxis? Be it anterior epistaxis or posterior epistaxis. Which is the artery of epistaxis? Sphenopalatine. Sphenopalatine is the branch of maxillary. Maxillary is the branch of. Which branches of internal carotid supply the nose? Anterior eighth model and posterior eighth model. Anterior eighth model projection on CT is known as nipple sign. Which artery does not contribute to the Kisselbach's plexus? Posterior eighth model. Posterior eighth model is a branch of ophthalmic. Ophthalmic is a branch of internal carotid. Where's the little area present, on the septum or the lateral wall? Septum. Which part of the septum? Anteroinferior part of the septum. Where is Woodruff's plexus present? Woodruff's lateral wall, where behind the inferior turbinate, 1 centimeter behind the middle turbinate, is the entry of sphenopalatine artery. Where do you ligate the anterior eighth model? Anterior eighth model, where do you ligate? Yes, we ligate it by the incision. Tell me the incision first. Yes, Lynch-Howarth incision. How much behind the anterior lacrimal crest? 24 millimeters. Where do you ligate the sphenopalatine artery? Sphenopalatine foramen. Yes, sphenopalatine foramen. So, we know the most common cause of orbital hematoma following FES. Following FES, patient develops orbital hematoma. That is most commonly following injury to which artery? Yes, anterior ethmoidal. So, we know all the arterial supply. We have also seen what the causes of epistaxis can be. Most common cause of epistaxis in children? Nose picking. In elderly or in adult? Idiopathic. Recurrent in young male should be investigated for angiofibroma. So, now we know the major causes. We know what these sites are. If there is a deep bleeding, yes, any child with epistaxis with bleeding in the joints, yes, hematomas, immediately tell me, what is your DD? Is it ITP? Is it leukemia? Is it hemophilia? Yes, it is hemophilia. Whereas if there is any child with epistaxis, along with that there is petechiae, then yes, then it can be a leukemia. Then it can be leukemia. So now we know everything and we are very well versed with everything. We are very clear, and now we are sitting in the emergency, and here is a patient who has now come to you with epistaxis. How will you manage this patient? You know all the causes, you know everything, but the main thing here is that whenever there is any epistaxis, the first aim is to control the epistaxis, yes, and then you can investigate the patient for the causes. But the first aim is to control the epistaxis, and again, this is something, pay attention, this is something which is asked repeatedly almost every year in your exam, which you as a doctor will be expected to be able to manage whenever you, in your family, anybody has epistaxis. And this is very common, yes. So what is the mode for management for epistaxis? So the first step for the management of epistaxis is to pinch the nose tightly and sit bending forward. Now, if it is not a very severe bleeding, okay, this much is going to suffice, and that is what you are going to aim at. But if it is a severe bleeding, you can see it's just pouring. So in that case, always get IV access also, and send blood for investigation also at the same time. Yes. So if it is severe epistaxis, then go for IV access also at the same time. So the first step is to pinch the nose tightly and sit bending forward or back like this. Yes. Just see here. Which one? First or second? Which one? This is first and this is second. Which one? Pinch the nose tightly and like this. This is what most of the patients do. No, this is incorrect. Is that clear? That is incorrect. That is not correct. That is incorrect. Yes, you have to ask the patient to pinch the nose tightly and sit bending forwards. Yes, what will happen if you sit like this? Then all the blood will go behind and the patient will swallow all the blood. You will not come to know whether it has stopped or not. So you have to ask the patient to pinch the nose and sit bending forwards and open the mouth and breathe through the mouth. This is what is known as Hippocratic or Trotter's method. So the first step is pinch the nose tightly and sit bending forward. This is known as Trotter's or the Hippocratic method. Okay, we have done this. Not stop. Now also what you can do at the same time while you're doing the Trotter's or the Hippocratic method is, you can, if at all available, you can give nasal decongestants. Nasal decongestants can be given. Nasal decongestants will cause decongestion, and then you can also ask the patient to pinch the nose tightly and sit bending forward. Okay. Now if did not stop, you have asked the patient to do this, did not stop, what will be a next step? Next step is, can you just visualize and can you make out where the epistaxis is from? Yes, usually it is anti-epistaxis. So what is the site of anti-epistaxis? Little's area, where is that present? On the septum, lower part of the septum. Yes, anteroinferior part of the septum. Can that be very easily visualized? It can be. So if it is bleeding from that area, you can visualize it. And that is the area which you can very easily cauterize also. Yes, so next step, don't jump on doing a packing, nasal packing. Nasal pack is very inconvenient for the patient. Yes, so always, if it is possible to visualize the area from where it is bleeding and you can localize that, yes, this is from the Little's area, what you can do is you can cauterize it. Can you see here? Here cauterization has been done and how beautifully it has stopped. So next is you cauterize. So you cauterize and cauterization can be a local cautery. It can be local with the help of silver nitrate, AgNO3 sticks. They come in the form of sticks, silver nitrate sticks, or it can be done with bipolar cautery. Now always remember, in the nose, whenever we use cautery, we never use unipolar. That can lead to blindness. We always use bipolar cautery in the nose. Okay, so we did that. Did not stop. It has not stopped. Still the patient is bleeding. Now, yes, now you go for the next step, and that is nasal pack. And you go for first anterior nasal pack. Have you ever done an anterior nasal pack? Have you ever seen anterior nasal pack being done? Anterior nasal pack? Yes. So how is anterior nasal pack done? a ribbon gauze is taken and it is impregnated with petroleum jelly, or it is impregnated with ointment, antibiotic ointment. Yes, and it is placed into the nose. As you can see here, from inferior you go on placing the pack in the form of layers till the complete nose has been packed. Okay, so you will do nasal packing in one nostril or both the nostril? One nostril or both the nostril? One. Bleeding is most commonly from the septum. For pressure on the septum, you will have to block one nostril or both the nostril. Yes, for pressure, we need to block both the nostrils. So, anterior nasal pack needs to be done in both the nostrils. In both the nostrils. And the instrument that you use for doing anterior nasal pack is this instrument, which is known as Tilley's nasal packing forceps. It has got a serrated edges, that is to hold for proper grip of the surgical materials. And also we can use forceps which have bayonet shape. This shape is what is known as the bayonet shape. These are known as bayonet nasal forceps. In fact, whenever any instrument is given to you and you see that the shape is a bayonet shape, yes, it is a forceps that is used in the nose. Yes, why? Because in the nose, like if you are doing endoscopic surgery, we are visualizing through the endoscope. There it does not matter. We are not visualizing from outside through the nasal cavity inside. Yes, but if we are doing something like we are packing in the nose, we have to see while packing also where exactly it is going. Yes, if you are cauterizing also. So you need to use instruments which do not occlude your vision. Now, if this was a straight forceps, so where I am holding here, in this end, and this is the area which is going into the nose, both of them are in the same line, so my hand will occlude my vision inside the nostril. So that is why these are bayonet shape, so that your hand level is either below or it is above, and you are able to see inside the nostril where exactly you are working on. So the bayonet nasal forceps can also be used, and they have very long jaws so that they can reach posteriorly, they can reach every area of the nasal cavity. Now, nowadays what is done is, instead of the ribbon gauze, what is used for anterior nasal packing is something which is spongy, that is known as the Merocil sponge. And this, when we put into the nostril, is like this, and when it goes and absorbs blood, it becomes swollen up like this. So this is what is known as Merocil sponge. Merocil sponge, it is very convenient for the patient also to have this thing into the nose. So it has not stopped. You have done anterior nasal packing and still bleeding. Now next what? Yes, next you will go for posterior nasal packing. And how do you do posterior nasal packing? Posterior nasal packing in the OPD is done with the help of Foley's catheter. So posterior nasal packing is done with Foley's. And this Foley's you inflate not with water but with air. Yes, not with water, because by chance it ruptures, there will be aspiration of the water. So you inflate it with air. So you have done anterior pack also and posterior pack also. So when you do the posterior pack and then pack anteriorly also, so it is a more tight pressure and more compression on all the area, on all the lateral as well as the septum of the nose. So if the anterior nasal pack has not worked, then you go for posterior nasal pack. And always remember, any patient where you have packed the nose, be it anterior posterior nasal pack, always you have to admit the patient. Nasal pack, with nasal pack you cannot send the patient home. Yes, he is, both his nostril, we did that, both the nostrils need to be packed. Yes, so you have to admit the patient, and this pack needs to be in place for 24 to 72 hours. And along with this, you give antibiotic prophylaxis to the patient. You have packed the nose. Yes, definitely there will be abrasion of the nasal mucosa that can lead to infections of the nose. So there is antibiotic prophylaxis needs to be given. Prophylaxis is given. Now the posterior nasal pack can also be done with the help of balloon. Yes, just note here, just see here, can you see this balloon has a structure where it can pack anterior nasal as well as the posterior nasal area. So you have packed the nostril, anterior pack, posterior neck, everything, and the patient is still bleeding. What next? What next? Yes, ligate. Okay, so you ask the patient to pinch the nose tightly. Did not stop. What you did? Cauterize. Did not stop. Next, anti-nasal pack. Did not stop. Posterior nasal pack. Did not stop. Everything you have tried. Still bleeding. Now, ligate. Okay, so now we are going to ligate. Ligate. What? Artery for epistaxis is sphenopalatine. Sphenopalatine is a branch of maxillary. Maxillary is a branch of external carotid. Which one will you ligate? Yes. Now, earlier maxillary and external carotid used to be ligated. Nowadays, 100% result is available just by ligating the sphenopalatine artery. Why earlier it was never ligated? Okay, tell me, the patient is bleeding and nothing has worked and you need to ligate the sphenopalatine artery. Where will you ligate the sphenopalatine artery? You will have to tell me this. Yes. Where will you ligate? Yes, at the sphenopalatine foramen. Where is that foramen? 1 centimeter behind? Middle turbinate. How are you going to reach that area, that posterior, if you do not have endoscopes? So before the advent of endoscope, maxillary artery used to be ligated. Nowadays, what gives best result is just ligating the sphenopalatine artery. And it has been believed that the closer the artery is to the area of leak, the better the result is. That is why when the bleed is in the nose, the closest is sphenopalatine. So the hierarchy of ligation is first sphenopalatine, next in sequence will be maxillary, next will be external carotid. So ligation will be, hierarchy will be, the hierarchy of ligation will be, first will be, yes, sphenopalatine artery. Where do you ligate sphenopalatine artery? Sphenopalatine foramen. Where it is, you already know, 1 centimeter behind middle turbinate. Okay. So now next is maxillary artery. Maxillary artery. So where do you ligate the maxillary artery? Yes, you are sitting here with your consultant and your consultant has told that ligate his maxillary artery. Okay. So ligate. Here's a knife. Take the knife. Ligate his artery. Where will you give the incision? Maxillary artery, you know the course, no? Yes. So where are you going to ligate? Where will you give the incision? Here. You will give the incision here, go into the intratemporal fossa and from there in through the pterygomaxillary fissure into the sphenopalatine fossa. Like that? No. Okay then. Okay, through the nose. Okay, very good. Through the nose you will go and where will you go? Sphenopalatine foramen. Will you find the maxillary artery there at the foramen? No, there we have the sphenopalatine artery. You want to ligate the maxillary artery. Okay. So from the sphenopalatine foramen you will go into the sphenopalatine fossa. Like that? You will widen the foramen, widen and now through the foramen you will go into the sphenopalatine fossa and you will ligate it in the fossa. Yes? No. Think of something else. Yes, what you do is you give a sublabial incision. You go to the sphenopalatine fossa, but where? Not from here, but through the maxillary antrum. Can we do that? Yes, so you give a sublabial incision, you raise the skin over the maxillary antrum, drill the anterior wall of the maxillary antrum, drill the posterior wall. Where have you reached? Sphenopalatine fossa. And what is that approach known as? Yes, Cadwell-Luck approach. Yes, what is this approach? Yes, the Cadwell-Luck approach. And what is this approach for? Through the endoscope, through the nose, through the sphenopalatine artery, sphenopalatine foramen. Yes, this is the sphenopalatine artery. This is the sphenopalatine artery ligation at the sphenopalatine foramen. Whereas, if you want to ligate the maxillary artery, this is the approach. What is this approach known as? Cadwell-Luck. This is the Cadwell-Luck approach. Yes, and it is ligated where? In the sphenopalatine fossa. Whereas this is at the sphenopalatine foramen. The sphenopalatine artery is ligated at the sphenopalatine foramen. Maxillary is ligated at the sphenopalatine fossa. Is that clear? So maxillary artery where? At the sphenopalatine fossa, and that is through Cadwell-Luck. Cadwell-Luck. Yes, not controlled. Next is external carotid. Yes, and where will you ligate the external carotid? Where was the external carotid? Yes, in the neck. How do you differentiate it is external or internal? By chance you end up ligating the internal carotid? No. You can differentiate in the neck itself. Yes, the one which has multiple branches, that is external carotid. Where do you ligate the external carotid? Above the first lateral branch, above the superior thyroid. Why above the superior thyroid? Yes, because where you ligate, the thrombus will form. So if it grows retrogradely, it will go into the superior thyroid rather than directly going into the systemic circulation. So external carotid, you ligate above the, in the neck. You ligate it in the neck. In the neck, right? And if still not controlled, then the hierarchy used to be anterior ethmoidal, right? Anterior and posterior ethmoidal. And posterior ethmoidal. Yes, so according to hierarchy, this is the order. But as I told you that 100% result is nowadays available just by ligating the sphenopalatine artery. So now ligation of anterior and posterior ethmoidal is considered as an adjuvant to ligation of sphenopalatine artery if epistaxis continues. So nowadays, if the epistaxis continues after ligating the sphenopalatine artery also, then you go for ligation of anterior and posterior ethmoidal. Okay, so don't get confused. Now, whenever it is asked hierarchy of ligation, always follow the order. Okay, it is sphenopalatine artery followed by maxillary and then external carotid and then anterior ethmoidal. But if it is asked as an adjuvant to ligation of sphenopalatine artery, which artery can be ligated? Yes, then you go for the answer as the anterior or posterior ethmoidal, whatever is there in the choice. Preferably the anterior ethmoidal. If both are there in the choice, go for anterior ethmoidal. So hierarchy of ligation, quickly tell me: sphenopalatine, maxillary, external carotid. Yes, then anterior ethmoidal. Now, in a patient of epistaxis, not controlled by ligating the external carotid, next step of management is, can we ligate internal carotid? If internal carotid is given in the choice, anterior ethmoidal is also given in the choice, will you think of ligating internal carotid? Never, never. Okay, so don't think that, okay, if I ligate the internal carotid, both anterior and posterior will be covered. No, you cannot ligate the internal carotid. Yes, patient will have, you will lose the patient. And what is the incision that is used to ligate the anterior and posterior ethmoidal? That is Lynch-Haworth. 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 So this is how you are going to manage a patient of epistaxis. Now, one condition needs a mention here. And there the management of epistaxis along with this is something more also. Yes. So what is that condition? That is hereditary hemorrhagic telangiectasia. The name tells you everything. It is hereditary. Yes, it is autosomal dominant. Autosomal dominant. Hemorrhagic, here the patient presents with epistaxis which is very, very recurrent. More than around 18 episodes of epistaxis per month. And this is because of telangiectasia, which is a abnormality, vascular abnormality where the blood vessels are abnormally dilated. This is also known as Osler-Weber-Rendu syndrome. And here when the patient has telangiectasias not only in the nose, but there are visceral telangiectasias also. So nasal, there is mucocutaneous involvement, and there is visceral involvement also. And in the nose, what you see is multiple telangiectasia. So here the management of epistaxis along with what we have just done is the same, but many a times that does not suffice. Yes, up till ligation, if it does not suffice, then in that case what can be done is embolization. Embolization can be done. And if that also is not helping, then what is done is septal dermoplasty. So it is asked that septal dermoplasty is done for which condition of the nose. So septal dermoplasty, what is the septal dermoplasty? Here the nasal mucosa, the complete mucosa which has abnormal blood vessels, abnormally dilated blood vessels, that is removed and it is replaced with skin. So it is septal dermoplasty. Dermis, the skin. Skin is now placed instead of the nasal mucosa. So septal dermoplasty is nasal mucosa replaced with skin flap. Dermal flap. And also here what can be done is Young's operation. There are abnormally dilated blood vessels and when they get exposed to the drying effects of the air, when there is crusting, then the chances of bleeding increase in them. So This is autosomal dominant condition. Nothing can be done. It is genetic, inherited. So what you can do is to prevent bleeding so that the bleeding does not recur so much and the patient will not recurrently be anemic and require blood transfusions. What you can do is you can do Young's operation also. Young's operation, by the way, is done for which condition? Young's operation? Yes, for atrophic rhinitis. So Young's operation is done here. So that was a little more than what we do usually for the management of epistaxis. So quickly tell me, you keep your pens down. Yes, you are sitting in the ENT OPD. Here is a patient who has come to you with epistaxis. Yes, how will you manage? What's the first step for management of epistaxis? Trotter's method. What is that? Pinch the nose tightly and sit. Yes, bending forward. Did not stop. Cautery, local cautery. Did not stop. Anterior nasal pack. Did not stop. Posterior nasal pack. Did not stop. Ligation. Ligation hierarchy is sphenopalatine at sphenopalatine foramen. Did not stop. Maxillary at sphenopalatine fossa through Cadwell-Luck approach. Next, external carotid. Yes, where is the anterior model ligated with through which incision? Through Lynch-Horvath approach, Lynch-Horvath incision. So that is what you need to know in the complete arterial supply of the nose, the causes of epistaxis and the management of epistaxis.